Hello, everyone. I'm Deep Medhi. I'm the organizer of SKC Science and Technology webinar series that we have been running since summer 2020. And we're in 2021 now. And today it's my great pleasure to have a good friend of mine, Dr. Wayne Vaught. He's a professor of philosophy and now provost and vice president for academic affairs at Utah Valley University. I know when he was my colleague at my University of Missouri, Kansas City. He joined UMKC in I think 1998, and he was a faculty in the Department of Philosophy and a joint appointment with the School of Medicine, because his doctoral dissertation is, although it is in philosophy, with a emphasis in medical bioethics, I believe
Mhm.
so. And in fact, before he came to MKC, he was a faculty in the School of Medicine at Drexel University prior to that. At the MKC, he started moving up and became the dean of the College of Arts and Sciences, and then he 2 years back, less than
It's
2 years,
almost 2 years ago.
uh,
Yeah, two.
got a position of this provost and senior vice president for academic affairs at Utah Valley University. So he jumped ship, I guess, to go there. And I know Wayne very well, but one of the things I always enjoyed about Wayne was that when I used to go to office in the morning, driving down, he'd be on the radio, public radio station called KCUR, and he's known as the ethics professor, and he will be on the show and talking about it. And I always enjoyed listening to him. He has a very interesting, folksy way of talking about it. He's, of course, he's a philosopher, but at the same time, he connects with people very well. And that's why I thought it would be, knowing his background would be a very interesting way to connect and understand how science and technology with ethics is an important thing for all of us to know about. Besides that, he has actually done on free time, whatever that means, he actually like refereeing in basketball courts in high school. So he has quite a few talents, I think. So with that, I'm going to hand off to Wayne Vaught, Dr. Vaught. Take it away.
No, thank you so much, Deep. It's a pleasure to be here and to have this opportunity to engage in what I understand will be an informal fireside chat type of environment. So if there are questions or things that come up, and if this goes whichever direction we feel it needs to go, I'm happy and flexible to move in that way. As Deep and I were talking about the session and what to focus on, I was throwing out some general ideas around medical ethics and end of life decision making and those types of things. But I think one of the issues that we can probably all pretty well relate to, unfortunately, now, regardless of where we are in the world, is this COVID pandemic that has created quite a bit of chaos for us. And not only the political and practical issues that we're all facing, but has really raised some interesting ethical issues in healthcare and healthcare delivery, which really reflects some of the challenges that bioethicists have focused on for many years. But now it's all within the context of the pandemic. And what does that mean for us? What are ethical obligations of healthcare professionals? What are the obligations of individual citizens and
Mhm.
communities as we try to grapple with the implications of this pandemic? And the way that we treat others. And so all of these raise some really interesting ethical issues that we can talk about. So what I really want to think about as we look at the issue of the pandemic, its impact on the lives of so many millions of people, or what are the moral obligations do healthcare professionals have to serve the sick and dying? And certainly globally, as we saw this pandemic come to the fore, one of the hardest hit, essentially initially one of the hardest hit groups were the healthcare professionals themselves. And so regularly we were just seeing reports on the news of frontline workers coming sick, dying, being exposed to COVID in the course of their normal jobs and duties and treatment that they were providing for patients. And it does raise a question of to what extent is there an ethical obligation for healthcare professionals to provide that care, especially when there are elevated risks, potential risks of injury to themselves, and obviously the consequence that might have not only for their own health and well-being, but that of their families and others to whom they have commitment. So what are moral obligations do healthcare professionals have to serve the sick and dying? What are obligations do administrators, community leaders have to ensure resources and planning? So certainly in the United States, there was a lot of debate and a lot of challenges about the federal response to COVID-19, whether states were being properly provided with the resources they needed, whether the healthcare professionals were being provided with the type of PPE equipment that they needed so that they could function in a safe environment. And so those two issues do kind of go hand in hand in the sense that it seems unusual that you would claim that someone has an ethical obligation to provide care and services for the community, but that the community is not ensuring that those healthcare providers have ample safety equipment in place and resources in place so that they can do their job in a safe manner, or safe as possible. And how do we fairly distribute limited resources? So now as we are in the immunization phase and the vaccinations that are now becoming available, the question immediately becomes, well, how do we fairly and equitably distribute those scarce medical resources? And so questions about resource distribution have puzzled philosophers and bioethicists for many decades, particularly around, in the 1950s and 60s as organ transplants and other medical technologies came to the fore, and really rapid technological development in that period of time through the 60s and 70s, then it really started to raise questions about distributive justice, about the ethics of access and equity, and the pandemic has, laid to bear the disparities that we experience, certainly again in the United States, but around the world, between those who have access to resources and wealth and opportunities and those who do not. And so it raises some interesting ethical dilemmas then that we have to think about around the pandemic, about the issue, just the basic issue of justice.
So
And,
Wayne, one
yeah.
question here is that when you think about the current situation compared to what you mentioned about the organ transplant that came out, is there from your perspective of your training and what, did you see something that was a big surprise this time than what you have seen before with, for example, organ transplant and the other medical issues?
I think that, what one of the biggest differences that, again, and I'm curious to hear about responses from around the world and others who are participating in this, but, at least in the United States, because we don't have a universal healthcare system, a national healthcare program, everything is largely privatized. I mean, one of the initial challenges around organ donations or organ transplants really was capacity and ability to pay. And so those who could get organs were those who had the resources to pay for it or provide that coverage. And then with whole organ transplants, or dialysis actually was one of the very first technologies that became available in the 1950s. And dialysis machines were dialysis machines were available prior to the invention of a catheter, a type of device that would allow multiple utilizations of dialysis. And so once dialysis could be used to treat chronic kidney failure, the earlies they had to go in and they would have to open a vein, and so there wasn't really the ability to do that over a long period of time. But then with Teflon, I believe they were can't believe the material that was on the needles that then were used, but it allowed for chronic dialysis treatments to become available. But those treatments early on were incredibly expensive and the machines were in very limited use. So it really was an issue of a limited resource. And one of the questions that early physicians had to debate was whether or not the patients themselves had access to the monies to afford it. Once dialysis became a federally funded program, then which it is now,
Mhm.
then that issue around the distribution became less severe. And so I think you're seeing that with COVID, because it is it's not a matter of whether you can afford it. It is now a matter, though, of who should get access to it.
That's
And these
correct.
were questions that came up even with the dialysis in the early days, because, even with the limited resources there were, and once you had enough people who could afford it, there were still questions about, well, should you use social worth criteria? How do you decide who you prioritize? Should it just be first come, first serve? Or should you try to target particular groups uh, because of the severity of their condition or whatever it might be? And so that's really has become a question that's come up as different states have struggled with how to allocate the vaccines. And largely it's gone to the highest risk groups. Those are the ones that they're focusing on. There have been in the news media
Mhm.
questions about, you know, donors, people well connected, being able to get
Right.
access to the vaccines when others who might be more at risk aren't getting access to the vaccine. And so is that fair? And so that same issue about distributive justice and,
Mhm.
the access and those with wealth or means or connections being able to kind of cut in front of a line when there might be decisions about, well, others should be prioritized for access to this vaccination, that raise some interesting ethical issues that are very similar to the issues that were coming up with dialysis in the early days.
So going back to dialysis, I have one more question now, Wayne, which is that, I mean, you talked about dialysis being one of the first thing and the inequity that, at the time, but are you familiar with how dialysis was handled in other countries when you
I'm
were
really
studying?
not.
Actually, very interesting. Okay. Hmm.
Yeah, no, I'm not aware of how it, I know that there are certain, like in the UK,
Hmm.
in terms of access, there, because the United Kingdom does have the National Health Service, and there are
That's right.
guidelines as to
Hmm.
who would get access to that, and it's not based on one's ability just to pay, as far as I understand. And so there are questions about how they, as a country, as the National Health Service, has made allocation decisions. And some of those were age-based rationing decisions, so that, once you got to a certain age, you wouldn't be eligible for certain types of procedures because it wasn't deemed to be appropriate.
Hmm.
You're going to want to invest those resources in ways where the people receiving the benefit are going to maximize the benefit from that. And some of this has been based on discussions in bioethics for a long time about whether some form of age-based rationing, what's the purpose and goal of medicine? Is it to
Hmm.
squeeze every ounce of life, every minute that you can get, or is it really to try to ensure that people have a normal lifespan? And
Hmm.
once you reach or near the end of that lifespan, the purpose and goal of medicine should shift, not to trying to prolong life as long as possible, but really to be more in terms of palliative care and ensure that you have a comfortable end of your life, but not using technology such as dialysis to prolong life at that
Right. Hmm.
age.
Yeah, that's an interesting issue. I don't know if you have read it. There's a book by Atul Gawande called Being Mortal. That's
I've
a
heard of that.
very, very interesting book. I read it. And so, anyway, so let's see. I already got a first question here. So I'm going to
Oh,
read
very
it to
good.
you. Do you think prescribing unnecessary medicines or more than necessary quantity is also an unethical practice? And similarly, prescribing to undergo unnecessary diagnostic tests also make poor patients feel uncomfortable.
So the question is, the use of unnecessary treatments
Yeah.
unethical?
So think about the Oxycontin in US, for example, right? It was overprescribed. So I think that's the context my friend is asking here.
Yeah. No, I think,
and how
yeah.
that impacts poor people also. So
Yeah, I think that anytime that you would provide a resource and what we call medically futile or issues of medical futility, that is, you're doing something that's not efficacious, not appropriate, it's not have any therapeutic benefit to it. Even, things, one of the areas that's raised questions and controversies is around the role of individual autonomy. A patient that comes in and says, okay, they have a cold, they have some, symptoms, and they go to the doctor and they want, say, antibiotics for their viral infection. And the doctor, and this has been a controversy as to whether or not, they shouldn't provide the antibiotic, even if the patient's asking for it, even if that's something they want, because it's futile to provide an antibiotic to treat a viral infection. But some will do it anyway, just to appease their patients or make them feel like they're doing something, especially if they're really demanding it and they don't want to lose their patient, and so they might do it. But that's raises the ethical issues. Ethically, no, they shouldn't be providing antibiotics in this situation, and not just, does it really cause a harm? Well, certainly if it's, the over prescription of antibiotics has been an issue just as much as the over prescription of opioids in the United States, and neither of them are appropriate. Even if the patient's demanding them or wanting them, if there's no clear therapeutic benefit from them. And so I think, healthcare professionals have an obligation to benefit their patients. Actually, I could slip down here and talk about these ethical principles that really sometimes will come into play to answer your question. So this right of self-determination, the right of respecting a patient's right to decide for themselves what types of things they want, what's the appropriate treatment, has to be balanced with these obligations to protect the patient's best interest, to act in their benefit, and to avoid causing harm or injury. And so you get into a situation like that where providing unnecessary treatments causes harm to the patient or potentially to the community. So certainly the overprescription of antibiotics is known to have detrimental impact on the community as you increase the risk for antibacterial or resistant pathogens to those antibiotics. Then you risk that now we have these resistant viruses or resistant bacteria out there that can cause greater harm to the community, and a physician who's abusing or misusing drugs is contributing to that harm.
okay, so these are the highest level, the 4 basic ethical principles that you focus on, I presume. So
yeah, these principles arose actually in the early 70s, late 60s, early 70s, when a lot of human subjects research and abuses of human subjects in research in the United States came to bear. And there was a document called the Belmont Report. And the Belmont Report was written in order to provide some ethical guidelines and principles for governing human subjects research. And these 4 principles were outlined in the Belmont Report. But then Beecham and Childress and some other philosophers really started to develop and expand upon these basic ethical principles for how they would apply, not just in the context of human subjects research, but how they could really inform a physician or healthcare professional's ethical obligations in all aspects of patient care. So. And we could talk about, as we think about and you reflect on what the ethical obligations are, there are so many aspects and sources of moral reasoning that really do come into play, such as religious beliefs and practices and faiths, and in particular where you have a great variation of religious practices and beliefs within a given area, it can cause ethical conflict. in the provision of care, where when you have different practitioners or different faith belief systems coming together around a single issue. Cultural standards, community standards certainly help and reflect the guidelines. So what's happening in the United States in terms of the question of the ethical distribution of the vaccine, I'm curious to know, in India, in Japan, in Australia, are there different community standards and sort of cultural norms that are create some variance in even the questions that get asked about access to and the appropriate distribution of this scarce resource. Then moral theories we could talk about, and codes of professional conduct. So Hippocratic Oath, the American Medical Association's Code of Ethics, so professional codes of ethics that govern and guide healthcare professionals in their practice. All of these things come into play. So, thinking about the historical context, and just sort of quickly, a bunch of slides, I'm not going to get through all of them, but, these are the issues that we're really facing. And we were just talking about the 1919, the Spanish flu, and
1918 Spanish flu.
1918, there have been, throughout the history of the humankind, there have been pandemics and epidemics and plagues that have confronted individuals, the physicians who are practicing in providing care. And it really has raised, it was one of those first questions I wanted to think about was, the extent to which that we could even say there is an ethical obligation for health professionals to provide care. Example, Carlos Urbani, some may be familiar with or not, but he was an Italian microbiologist and was the first who diagnosed SARS. And he had been a physician. He was working with the World Health Organization, flew to and was working in Vietnam and the hospitals in Hanoi where the SARS outbreak was developing, and was studying and providing care, and would be one of the early casualties of SARS, as he died 4 weeks after he flew to Vietnam to provide care. And so this kind of reflects what we're experiencing, or had been experiencing, certainly over the past several months, of healthcare professionals on the front lines being subject to these risks. And
even
so,
I think one of the early doctors in China, in Wuhan, who identified, and we thought something strange, he died also. So very similar to what you talked about, so there are a couple of other questions comes in,
sure.
and let me read it. How ethical is disowning responsibility by doctors after any treatment or surgery goes wrong?
The ethics of disowning one's participation in something when it goes wrong.
Right, from a doctor, I guess. That's
I think that you have I would argue that you do have an ethical obligation, responsibility to stand behind and to take responsibility for what you have done. The issue of medical malpractice has been one, especially in the United States, that has been a concern. And interestingly, in this, whether you think about it from an ethical obligation, so if I would say in terms of the virtue of honesty and ethical integrity and truth telling, these are all, no matter which ethical theory that you're coming from, are almost always highlighted as an ethical duty, that you have some ethical duty to be honest and forthright and forthcoming. And if you've done something that has caused harm to another person, the ethical duty, it would seem to be to take responsibility and to acknowledge that. So you could say there's that ethical duty to do it. And one of the things that some studies had discovered was that when families lost a loved one and there was medical malpractice at play, that the families tended to be less litigious and less likely to seek out the most aggressive recourse against a physician or a healthcare professional who might have accidentally done something if they owned it. The hospital calls and says, we're sorry, we made a mistake. Our mistake has resulted in the death of your loved one, and we want to, we need to make amends. And so it appears that there have been likely situations where, settlements would be reached that would be much less than what would have been reached if, the hospital shuts up and doesn't want to say anything to anybody. And then we get attorneys involved, and things get kind of ugly. So there could be both practical reasons for wanting to be honest and open when there is an error. But yeah, I think that if you've done something and it's gone wrong, and it may or not have been your fault. There are all kinds of things that can happen, and in the litany of potential side effects or things that can happen from taking almost any drug or any procedure, things can happen that are unforeseen. But then there can be things that were happen that are a result of a mistake. And if you've made a mistake, I think you should have an ethical obligation to acknowledge it and be truthful about it and forthcoming about it, and address the consequences of that mistake in a meaningful way with the family who's suffered the loss as a result of that mistake.
Very good. There's another question is that should men be used as means but not as an end? So what do you think? What's your opinion
Well, that
or view on it?
raises actually a very good and a very deontological argument. Immanuel Kant
Yeah.
was the philosopher who argued, in fact, he had this theory about ethics, and we don't have to get into the details of that, but one of his arguments, one of what he called his a second formulation of the categorical imperative, was that one should never treat any man merely as a means, that they should always be treated as an end in of themselves and never merely as a means to an end. Now, what Kant meant by that wasn't that you don't treat others as a means to an end. I mean, we do it all the time. I go to the grocery store, I want to buy my groceries. I'm using this cashier as a means to an end, that I can exchange my money. I get the food, I get to leave the store. I've now used that cashier as a means to the end that I want, which is to take some food home. Our students who come to our classes, they're using every professor as a means to an end. They want to learn something, they're engaging with that faculty member, they paid their tuition, they expect that we're going to now provide them with a service, and I'm being used as a means to a particular student's end. So Kant really wasn't concerned about that, and I think that we always use everyone as means. What Kant was concerned was that you wouldn't treat someone as an end in and of themselves. That is, that you were to treat them merely as a means, that they could be, disregarded or disrespected. And so one of the ways actually in which this can kind of come up is that in what we call, it's around the issues of conscience. So take a pharmacist who feels that they don't want to dispense a particular drug because it's an abortifacient drug, or because it's a birth control device or birth control pills because of religious objections. Then the question becomes, well, if I force someone to do something that violates their own values and religious beliefs or cultural beliefs or perspectives, then I'm treating that person merely as a means to an end, not not respecting them as a moral agent in and of themselves. So I think that the issue really becomes one of recognizing that when I go to the doctor, and I want him to or her to treat me and give me some medication so that I get better, I'm using him or her as a means to an end, but I have to treat them with some level of dignity and respect and acknowledge them as being moral agents. in addition to being healthcare providers, and to violate them in a particular way would violate what Kant would call this formulation. So yes, I think you have an obligation. I think it's fine to use people as means to an end. You just have to do it in a way that respects their dignity and self-worth.
Mhm. So very good. Let's see. There's a yeah. The one person from Japan wrote that the medical system is very well regulated there, and they have a very effective universal insurance scheme. So
Mhm.
that also addresses equitability very well. If that
Much
can
better.
be done
Mhm.
much better. Um, Here's one more question here. Medical ethics is normally talked and also taught. Perhaps professional ethics is of concern in all businesses, right? Whether it is engineering ethics is, or computer software ethics that we talked about, but those
Mhm.
are very seldom discussed. Though many health professionals may be result of using engineered system and products. So, it's sort of a interesting thing, dynamics that can come in there, I think so. So,
No, there are almost all professions have codes of professional conduct and codes of ethics, whether you're a healthcare professional, whether you're an engineer, there are engineering ethics and codes of ethics that govern that. If you're an accountant, if you're there are certain expectations when you
right.
take on fiduciary roles in different professions. You have ethical obligations to those, whether you're a lawyer, whether you're an accountant, whether you're a nurse or a physician. When you take on the responsibility and accept the responsibility of care for another human being, whether it's their health or whether it's their money or whether it's building a building that you are assisting with, you take on certain ethical obligations, and most of those have been reflected in varying codes of ethics that kind of prescribe what a professional's conduct should be in given situations.
Yeah, for example, with our computer science major, we require them to do the software ethics related aspect, get
Hmm.
some background on. They complain about it when they take it, but
Of course they do, right?
and so, but it is, I think, extremely important. Similarly, you can think about, a civil engineer understanding the implication of building a bridge. I mean, are
Hmm.
they putting the best software, I mean, best professional practice to it, so that, not cutting corners. So I think, I mean, unlike medicine, where there is a, the you kind of, follow certain, principles, or, agreeing to the Hippocrates of oaths and things. That's probably not there in other disciplines as much, but
Right.
probably it's a good thing to have in many disciplines.
Absolutely. Hmm.
So I didn't mean to stop you from going to the next slide or anything,
Oh
but
no,
you're
no,
good.
this
Okay.
is this is a great conversation. And
Yeah,
again, I'm
right.
happy to
Yeah.
go whichever way it went. I'm just going to skip through some of these. These were some of the early, and this is even last fall here in Utah. By last fall, there were 1,100 healthcare workers that had been contracted COVID-19, and I know that number has certainly increased significantly. And it's not just COVID, but we have avian flus,
Mhm.
H5N1, Ebola, plagues, smallpox, which hope has been eradicated, but a few years ago there were concerns that there might be weaponized smallpox available to some governments, and concerns that there
Right,
actually
right.
could
Hmm.
be a re-release of this horrific disease again. And so we've been largely confronted with this, and the response has been, from even in the plagues in 166, Galen was reported to have fled during the plagues. And so the idea that physicians, when they would encounter a plague in a given area, that they might actually abandon their posts in a plague in 1665, physicians were believed to largely have deserted their posts. But I don't know if you remember Shona Ray, Deep, when she was a history professor
Right, I do.
there and unfortunately passed away. She was in Italy at the time, but she had done some research. She was they called her the Black Death doctor. I can't remember what her title was, but she studied the plagues in Italy and in Florence. And she wrote this paper, Boccaccio and the Doctors, Medicine and Compassion in the Face of Plague. And what she found was, in looking at wills that had been executed in Florence here in the 14th century, she found that many of the witnesses to the execution of these wills were doctors and
I
professors
see.
of medicine and barber surgeons. So while there were clearly physicians that no doubt abandoned their posts and ran off to the countryside to escape the plague, not unlike what we experienced in the United States. I mean, people were fleeing out of New York, those of wealth and means, they were leaving and going to their summer homes to get out of the city so that their families would be protected from what we were seeing in New York City. And so this is just throughout the history of humanity, there seems to have been this question and concern about the roles and responsibilities. And even in the United States, we saw this in the 1980s when HIV was first diagnosed. Certainly in the early days when there was uncertainty about it, what it was, where it came from, how it spread, and how the likelihood of contagion. There were healthcare professionals who would refuse to treat HIV patients.
Right.
So this required the AMA actually to take a relatively strong position, but that physicians may not ethically refuse to treat a patient whose condition is within the physician's realm of competence. In this case, because the patient was seropositive. So this is just to suggest that, as the profession and the professional codes of ethics started to look at this, they were taking a stand that health professionals do have an obligation to provide services, even in the light of potential risk or increased risk of harm to themselves. But the extent of that is still something that we kind of really have to get our hands around, because I don't think, throwing a bunch of healthcare professionals into the mix of all of these patients with COVID and not providing them with N95 masks or protective devices or other PPE equipment and expecting that they will just go in and be exposed and potentially die from this, I think is also unethical. That would be, as that last question, that would be to treat them merely as means to an end, not to respect them in and of themselves, that they are people that need to be treated fairly and equitably, that you just think, well, you're a healthcare professional, you have to go in and do this without care and attention to them individually, I think would be to treat them then merely as a means and not as an end in of themselves. And, in studies that have been done, most healthcare professionals actually take a stand that they're willing to take on the risks and assume the risks, but only if they have, reasonable training and resources and equipment that would provide some reasonable level of protection from the harm that they're facing. And that seems, I think, as we think about the codes of ethics and how they have changed, in this was removed from the American Medical Association's Code of Ethics in the 1950s. But prior to that, the code had said when pestilence prevails, it is their duty to face the danger and to continue their labors for the alleviation of suffering, even at the jeopardy of their own lives.
I see. Very interesting. Okay.
And so that was deleted
That was
from the
deleted,
code of
right?
ethics.
I
So
see.
it's no longer there, but
I want.
it's raising this sense of what is the professional's ethical obligation in light of this grave risk? And I think there is some, but it can't be, I don't think it quite should go quite as far as was in this code of ethics, for that very question that came up, because this looks like we might now be treating them more merely as a means to an end than as end in themselves.
No, this is very interesting to hear that the code. Okay, sorry, you're going to read some other code or something.
Oh, I don't have to, but this is actually the current code, and I haven't updated it. I believe this is still the code of ethics, but you can see that the code of ethics for physicians from the American Medical Association recognizes that physicians have an obligation to provide care, that holds that they have a duty to accept greater than usual risks, but it goes on to state that physicians should balance that immediate benefit to their ability to provide care for patients in the future. Basically saying, well, you don't have an obligation to risk your own life if that would prevent you from being effective in providing care to patients in the future. So it's a much softer version of what we saw in the Code of Ethics 100 years ago. It's saying that there is a duty, but it's not an absolute duty, and it's one that needs to be balanced with other duties that a physician might have.
That's right. I mean, even with pre-COVID, when a surgeon goes to an operating room and does an operation, they wear mask, right? I mean, it's
absolutely.
It's like it's a given, right, for that situation, because I don't know what it would be, blood spilling, anything can. So I think that's a protection that's actually is there. Here's a comment again. Let me read this to you.
Sure.
The government of India in 2017, it regulated the price of artificial heart stent for angioplasty and brought the price down to almost 80%. And before it was more or less a raw trade, and it was more expensive. Only the rich can afford this sort of a thing. So I think this goes into a very interesting question from the post. This actually raises a very interesting question about that. What does the role a government play in the ethical aspect of bringing equity, to provide healthcare in general, and then special, expensive, procedures to the public, So,
no, that question raises some really deep interesting philosophical debates as well. And when we get into these questions about access to resources, the issue that we talked about at the very beginning about dialysis is the very exact same thing. Dialysis was incredibly expensive and very limited, and you just couldn't get access to it back in the early days. And it wasn't until in the United States that the federal government provided funding for anyone who was placed on dialysis, that you saw the prices then, start to stabilize and the access become available. So that, there are two different thoughts on this. Robert Nozick and John Rawls are the two philosophers, contemporary philosophers. Actually, they both died just a few years ago. They were both Harvard philosophers who wrote about on very polar extremes about the nature of justice and obligation and duty. And Nozick took a stance that, well, what you have an ethical obligation, that we have an ethical obligation to provide people with what they're entitled to. And, if you have the resources to afford something and others don't, then to redistribute wealth in order to allocate these resources according to Nozick would raise some ethical questions about taking things and forcing people to kind of work, for free and take their money and redistribute it to provide that same resource to others. And then John Rawls took a much different perspective on the question of distributive justice and developed a procedural definition of justice that would really try to provide some sense of equity. That he said that justice would put these hypothetical agents behind a veil of ignorance, not knowing whether you're going to be sick or healthy or rich or poor, what your actual circumstance might be, but knowing the way the world works, what types of distributive principles would they use? And he said that, people would choose these principles that would provide a fair distribution of resources, unless an inequality in distribution would maximize those who are most worst off.
Mm-hmm.
So that would give you some sense of saying, it's ethically defensible to redistribute wealth, to tax, and to take those tax dollars in order to provide
Right.
resources
Mm-hmm.
that would allow everyone, regardless of whether
Right.
you're rich or poor, that you
Mm-hmm.
should be able to have certain basic health access to certain basic healthcare services in order to just to live.
Mm-hmm.
And others would take a different stance on that. And we're seeing in the United States in particular, I mean, that's fundamentally the debate. And it's, we have what's now called the Affordable Care Act, which
Right.
was approved under the Obama administration, that sets certain guidelines and parameters really designed to ensure that every American could get access to healthcare insurance and access to healthcare. And there are those who are adamantly opposed to that and do see healthcare more as a right, kind of in this Nozikian sense. I think that
Mm-hmm.
that you shouldn't take my money away from me and give it to somebody else through taxation in order to provide this service. And so you get this real tension
Right.
about the nature of justice and the definition of justice that can be difficult to discern. My leanings are more toward the Rawlsian notion
Right.
of justice and equity.
Mm-hmm. So here's a doctor who asked me a question, said that nowadays the cost of medical expenditure is increasing a lot, with new equipment, new procedure. If poor people cannot afford this treatment, and so the advances of medical science seems to be benefiting more the rich people. I mean, the question is it
Yeah.
ethically acceptable, right? So,
Yeah, that gets back to the same tension that we were just talking about. And even for Rawls, I think I think that um, we can't provide everything to everyone and all of the most advanced technological advances. We have to recognize that there is a limit to what can be provided. C. Everett Koop was a Attorney General of the United States back under Reagan administration, but he made this interesting claim. He said, that Americans have these three incommensurate demands on the healthcare system, and that is they want the most advanced, the most sophisticated, the newest medical technologies available. They want it to be made immediate. They don't want to wait for it. They go in, they want to get it, and they want it to be cheap.
right.
And he said you can have any two of those, but you can't have all three of them together. And so healthcare systems around the world, that's the balance in the equation that they try to look at, is that, well, we're trying to balance cost and access and new technologies. And so you can have high-tech medicine, you can control the cost, but then you're going to get into the queues that we'll see around the world. So you're going to have to wait a little bit. We're not going to have as many MRI machines available. That here we got them on practically every corner. In other countries, you'll have this is more of a limited resource so that you can control the cost and provide access to more people. And so that's, to say that's one way in which we might try to ensure equitable distribution, but it does raise the question of immediacy of access. And, one of the things that that some have argued for, and I would tend to agree, is that it's probably morally defensible to say that there should be at least some basic minimum of
Right.
healthcare, some
Right.
basic
Mm-hmm.
minimum practices, whether it just be, access to preventative care, prenatal care for women having children, some basic healthcare provisions But to recognize that, there may be some really high-tech, innovative treatments that maybe some people can't get access to. And there you get into questions of, affordability and who can pay for certain types of things. And what's medical tourism now, as it will be called.
Right.
People who can go from country to country.
Hmm.
Maybe they'll fly to the United States, or they'll fly from the United States to somewhere else. I know people that will go to Mexico for certain types of treatments that they can't easily get here, or people come to the United States for certain types of treatment. But these are people with money and wealth and the
Hmm.
ability to um, tour to other countries to get access. And it's a recognition that there are certain limits to what we can do. But at least if we're trying to provide a safety net, a basic access of resource, I think that we're making progress. And here in the United States, certainly prior to the Affordable Care Act, but even still, there are a lot of uninsured Americans. There are, people who just don't have access to insurance. And subsequently, my wife, who is a nurse practitioner and has worked with this group, she's sometimes would be so frustrated, is like, you know, they can get access to drugs, even basic drugs, that her clientele, her patients can't. They just don't
Hmm.
have the money, don't have insurance.
Right.
I can go in and get my drugs and they're paid for by my insurance. And unfortunately, these other people are going to have much shorter lives simply because they don't have access to a quality care. And that is an ethical issue that we have to
Absolutely.
struggle with.
I mean, and that impacts many other ways, economic, your education,
Absolutely.
everything and whatnot. So
Mhm.
I'm going to veer off to a slightly different topic now, Wayne,
Sure.
which is to do that. Let's talk about what's happening with gene, chromosomes. We're at a point now we are being able to splice genes. You can do gene therapy, and you're going to be able to
Hmm.
make changes to your gene, and your DNA. And so that, what, have you given some thought into the ethical issues around that kind of, what's coming up actually? And
Yeah.
let me connect one more piece to that question now. I mean, basically, the reason I brought it out, this is connects back to the medical side of the thing. I said that, let's say when because by looking at my DNA, that there's no chance I'm going to survive beyond tomorrow, let's say. You know, I'm not surprised it won't happen, So then he said, you're a doctor, what are you going to do with it? That's one aspect of the question, obviously. The other is that, is there a kind of a line that can be drawn where he says that, these are not an ethical thing, or is it a kind of like a moving boundary?
Hmm.
It's like a drawing a line on the sand sort of an idea. So any thought on this sort of aspects, I guess?
Yeah, it's these become really high tech, new, innovative technologies and treatments. So it raises the specter, one, of questions of who's going to have access to them, and particularly new and innovative things. And oftentimes, insurance companies won't even cover or provide, resources to cover some of these sorts of treatments. So that one question. I think, largely with genetic engineering and gene splicing and the use of genetic uh, technologies to treat diseases and disorders raises one, really kind of, you're starting to question what are the downstream effects of some of these technologies, um, and how it fits into the reproductive cycle of human beings, and the potential for harms to future generations that
Right.
could be impacted by some of it. And even the research itself. There was a guy, Jesse Gelsinger, who he was a patient. He had a genetic disorder, and they used a modified genetic technique to try to treat the chronic but not severe genetic disorder that he had.
Mm-hmm.
He ended up dying in part because they missed some contraindications, some other things that they should have realized when they were doing his workups and lab work, that he shouldn't have been given the treatment. But they pushed forward anyway. And so that actually caused a lot of consternation and reevaluation of the ways in which federal guidelines protect human subjects in research. So on one hand, you have the technology itself, the introduction of new and innovative techniques and the potential harms that those can cause to the individuals who receive them. But I think one of the real concerns is making sure that whatever we're doing, particularly when we start going in and manipulating genetic
Right.
material,
Mm-hmm.
that we're not doing something that either can cause unforeseen harms to that individual, especially with really innovative and new technologies, or potentially harms to the community or to future generations of that person. I think in a lot of these techniques that it's limited, so it doesn't get into the reproductive genetic materials, and so the likelihood of it spreading from one generation to another may be quite limited. But
Mm-hmm. Mm-hmm.
those would be, I think, some of the biggest risks. So you get the issue of, again, these there's been a long awaited discussion about this customized medical treatment,
Right, right, right. Yep.
that
Mm-hmm.
you develop treatments that are unique to the individual and their unique genetic
Right.
conditions. But gosh, that's very expensive. If we
Very,
could
very
get to that point, it'd be
right.
incredibly expensive.
Exactly. Right, right.
And so do
So,
we invest in that
mhm.
to get, a limited number of people, these really innovative techniques, or should we really be trying to focus on making sure that at least everyone can see a doctor every year and
Mhm.
get treated for basic conditions before we invest a lot of money in some of this other work? So,
Yeah, no, no, that's why I wanted to get some your take, because that's also goes to the cost aspect. And
oh,
also
absolutely.
again, who can afford it, right? So,
Mhm.
I mean, there's another question here that there must be health policy for people, which it should be compulsory and, implemented by government.
Mm,
That's a very important point about the whole health policy. But policy by itself, to me, is not sufficient for a couple of reasons. One is that who bears the cost?
mhm.
You can have a policy saying that let's say driving, you're not supposed to go beyond the speed limit, right? You still do, right? So policy cannot fully
I
be
frequently do.
well, but I do too. But the policy is not implementable in that sense. So the cost obviously comes with it. That
Right.
needs to be taken. Second thing that is very important to realize, also going to the same person as the question, the cost of medical, like going to the individualized medicine or whatever we call it, is actually going up. Instrumentation is expensive. So you cannot have what I call is a sort of a static health policy also, because the policy has to change with time. Because you
Yeah.
cannot say, we're going to just do it this way, because
Right.
so many other unknown factors can come over time. So it's an interesting question about the policy, but I
Uh,
Yeah.
wanted to
I would like to add one point
go
to
ahead.
there, because I belong to the manufacturing sector for the healthcare facilities. And in the recent time, since the pandemic has emerged, we have seen that there is a very increasing trend of ordering some devices, which used to be alternative devices before the pandemic. Now it has become the essential devices due
Mhm.
to the like some protective gear. For example, to filter the fume during a surgery when there are a lot of fumes coming out from the patient. Previously, the surgeon used to choose it, like whether or not to use it or not. But now that has become very essential. So we know that
Mm,
due to that
mhm.
factor also, it has the cost of the healthcare has increased like for multiple times.
Yeah.
So I think those also the point when the government construct the policies, I think they should include those points like during emergency, how should they handle this type of cost? Because those were alternative before. Now it has become no longer
Optional
alternative now.
before, now it is
Yeah.
more required, right? Yeah.
No, that's a very good point. Yeah, no, that the conditions themselves have just exacerbated an already difficult problem in terms of cost control. And now again, this gets back to this, the issue that we were talking about. Well, it makes sense that you would want to add new protective equipment and devices to protect the surgeons who are providing this care, and that increases the cost. And someone does need to ensure. I think it would be unethical to say, yeah, well, we're not going to provide that, and you just have to go in and risk increased exposure when that can be avoided.
So we're coming to the end of the hour. Wayne, did you want to kind of give any closing remarks, any points you want to point so that we can wrap it up here?
Yeah, I don't know that I have anything exactly to say other than, this has been a really interesting time over the past year around the globe, as we've watched how different countries have tried to combat and address the challenges, some more effectively than others. And, when you do have organized, coordinated efforts to try to address things, and deliberation about how to do it in an ethically and professional way, I think you see better results than when you don't. And so I guess that's all I would say. So
all right,
this has been fun. I haven't been able to see too many of you, but hopefully this was hopefully you found this at least curious, if not helpful.
Right. I'm very sure they're curious, they're asking questions, and we will do a feedback afterward to get some feedback on how it went. And thank you again, Wayne. And so thank you for
Thank
spending
you so
the
much,
time.
Deep, for inviting me. And
it was great to have you talk, and with your experience of handling medical bioethics for a long time. So thank you. I'm going to